Welcome everyone to our second episode podcast with Preventi.AI, showcasing some of the newest information in preventative health. And we had as our guest Dr. Shone Almeida, who is a preventative cardiologist here in the Tampa Bay area. And welcome, Dr. Almeida. And could you just tell us a little bit about yourself in this space of preventative health?
Absolutely. Thank you for having me, Jim. So Shone Almeida, I'm a general cardiologist here in Tampa, but I specialize in two really important things that go quite nicely together. One is in cardiac imaging. So I read a spectrum of cardiac CT and cardiac MRI and echocardiography, in addition to my clinical role. But my passion is truly in heart disease prevention. And imaging and prevention really go hand in hand nowadays with everything that we have to better visualize heart disease and diagnose heart disease earlier. So heart disease prevention, early recognition of disease is truly where I focus my practice.
Welcome and thank you. So just to frame this out a little bit, I want everybody to kind of be in the framework of the where we are with preventative health and cardiac imaging. And I just want to reiterate some of the stats that we currently are having. And heart disease remains the number one killer in globally, the number one public health epidemic. Every 2 to 3 seconds worldwide, there's a heart attack, and it accounts for one in every four deaths. Just to personalize it a little bit, I have a few fact information uh, under the idea of low risk. 70% of people are still considered low risk at the time of their first heart attack. And as an example of that, Bob Harper, he was the host of The Biggest Loser, and he was a celebrity trainer, and he
Mhm.
died and was resuscitated while working out at the gym. So I want to just kick off of that idea of low risk, right? This
Mhm.
preventative space. So with the idea of calcium scoring, how does that fit in? Or if somebody has a desire to really get ahead of heart disease, where should they fit into currently into the options that are available with medical tests?
Yeah. Jim, this is a great question. And that story that you mentioned, unfortunately, isn't unique. It is true that we've made a lot of progress in heart disease over, say, the last 3 decades. Heart attack risk has come down. Overall disease prevalence has come down. But actually, if you look at that CDC data starting around 2010 or so, the trend has shifted, that the prevalence in both men and women are on the uptick. Now, whether that's driven by obesity or other societal factors or other comorbidities, I don't know exactly what the root cause is, but we're starting to see that despite our best efforts of saving people's lives in acute heart attack, that disease prevalence we've not really impacted tremendously. And in fact, now seeing just the opposite. We're seeing a rise in disease prevalence. So I think the first step is to ask the question, right? If you're someone who's middle age, let's say late 30s, 40s, 50s, early 60s. And the reason I pick up those age groups is because if you're much younger than 30, maybe your risk is going to be pretty darn low. It's not impossible, obviously. There's certain disease scenarios where heart disease can occur very early in life. And if you're above age 60, well, a lot of the times our population-based risk tools that we have, our risk calculators that a lot of your physicians and your primary care doctor or your cardiologist will use, they work pretty well. But for that large cohort of patients in the middle, population-based risk scores don't do such a good job. Now we've made some refinements, and some of the new prevent risk scores that the latest cholesterol guidelines use actually work a lot better, but there's still gaps, particularly when it comes to women and younger age. So I think you still have to start with the question, right? what is my heart health? Am I sure that I'm in as good a shape as I think I am? And what's on the outside doesn't always match what's on the inside. What I mean by that is your age doesn't always match what your vascular age might be. So then you really have to go beyond just asking the question about am I at risk to now taking a look. And there's a couple ways to do that. For the right individual, meaning you have some risk factors, whether that's diabetes or obesity, or you smoked, or you have a premature family history of heart attack or stroke, or you have some chronic inflammatory disease like lupus or psoriasis, right? Or you're a woman who's had breast cancer radiation in the past, or you've had preeclampsia in a prior pregnancy. These are all risk factors that we recognize as causing premature plaque. So if you can identify one or two of these risk factors, which most Americans can, then you have to take it a step further. Now, most people will have things like cholesterol and other biomarkers checked. But if you ask me, those are merely surrogate